Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place where I get to spoon feed you guys the latest and greatest of emergency medicine. Now, this is the audio version of the past week summaries, which this week were brought to you by Anna Harp, Alexander Sheehan, Ketan Patel, Megan Hilbert, Shannon Marcus, Doug Wallace, and Clay Smith. So let's get straight into the first article, which was titled As Needed Albuterol-Budesonide in Mild Asthma out of the New England Journal of Medicine. A large proportion of severe asthma presentations are due to people who have mild asthma, which can be otherwise fairly well controlled or at least not causing a lot of day-to-day symptoms. Around 30% of asthma deaths and severe exacerbations are caused by these people with mild asthma. Now, typically, up until the last couple of years, you would see people with mild asthma, they would only have a SABA, a short-acting beta agonist like salbutamol, albuterol, and that was the only medication that they would have. So when they had some symptoms, they would use their SABA, kind of get rid of their symptoms, but they were not really treating the underlying disease of asthma, which is that inflammation, swelling in the lungs, and causing obstruction. Now, over the last couple of years, there has been an update in guidelines, including those by GINA, the Global Initiative for Asthma, that is to stop using SABA monotherapy. And instead, you should only use your SABA in combination with an inhaled corticosteroid. Now, most of the data for this so far has been in maintenance therapy of asthma and not necessarily on a kind of as-needed basis. The Mandela trial showed us a lot about this new kind of change in therapy, but now we have the Bactura RCT, which instead was trying to see if you could use it as needed, which is how a lot of people with mild asthma were using their SABA before. They have some symptoms, maybe they've got a cold, they use their SABA a little bit. But now what if we replace that and use the SABA with inhaled corticosteroids, budesonide specifically, and put those together in the same pump and use that as needed for these patients? This was a phase 3B randomized double-blinded trial which investigated just that. And what did they find? They found really quite good effect. Compared to albuterol alone, albuterol with budesonide significantly reduced the risk of severe exacerbations, almost by half, a hazard ratio of 0.53. That's 5% versus 9%. That's a number needed to treat of about 25. And these are severe exacerbations. These are quite important. Also, the use of systemic corticosteroids in these patients was reduced by 63%, which is a huge amount of decrease. All that without a difference in adverse events between the two groups, which we wouldn't really expect a lot of. Now, this trial was only in adults, that's those over the age of 18, whereas the GINA guidelines do recommend SABA with budesonide for all patients 12 years and older, so there might be a little bit more work to do here in other trials. What was very interesting about this trial was that it was a completely virtual trial. Of course, it happened in the real world, but there was no face-to-face patient-doctor contact. They just did all follow-up visits virtually. Very, very interesting stuff. It's really cool to see that. I bet that saves some money, and this was still a high-quality trial. We've covered articles before which talk about the importance of emergency physicians giving inhaled corticosteroids to your patients that you discharge with asthma. And this is really hammering home exactly why that is. I will no longer be giving my patients SABAs alone. I will give it with another pump. Now, unfortunately, those combination pumps are not necessarily covered under the provincial insurance that we have in Canada right here, right now. So I'm probably going to have to be giving 2 pumps to all of my patients, but I think that's fine. You would just have to instruct them to use them together. This trial, given that it was a virtual trial, had no pulmonary function testing done for any of these patients, and I think that's realistic. I don't do any pulmonary function testing on any of my patients. I don't necessarily look for it in the chart, and so I think this is a more pragmatic style treatment for these patients. I hope you're hearing this, and I hope you're thinking about looking up the GINA guidelines and updating your care for asthma for the future. I think this is really here to stay. This is not the first trial that shows this, and it's just going to continue. This also makes more physiological sense for our patients to really treat the underlying problem in asthma, which is inflammation. In a spoonful, this is some practice-changing stuff. I personally will no longer be advising monotherapy with SABAs for asthma control or PRN use. Not just from this trial, but others as well, I'm going to be giving a lot more of my patients inhaled corticosteroids. Okay, let's skip over to the fourth article, titled Efficacy of Intranasal Ketamine in Controlling Pain Caused by Bone Fractures, a Single-Center Double-Blinded Randomized Controlled Trial, out of the journal Injury. Now, we know that ketamine is a great medication for pain, as is morphine, but most of the trials look at IV ketamine, and not necessarily IN ketamine, intranasal ketamine. And so this trial wanted to do a direct comparison of intravenous ketamine, intravenous morphine, and intranasal ketamine in patients who have fractures. I like to read the introductions to these papers, not necessarily because I need the information that they're providing with topics that I'm fairly familiar with, but just because they say a lot of weird stuff sometimes. Like they said, pain can increase susceptibility to disease and impair the immune system, which is like believable, but I would have sure liked to see a citation for that sentence. So they compared patients who were getting intranasal ketamine at 1 milligram per kg against IV ketamine at 0.5 milligrams per kg, a fairly generous pain dose, versus morphine IV at 0.1 milligrams per kg, a very typical dose of morphine. Now, is ketamine going to work just as well intranasal as intravenous? Of course it is. All that matters is how much drug gets into your system and not necessarily how you get it there. So they measured pain scores in 140 patients at 15 minutes, 30 minutes, and 60 minutes, and they were all equivalent across the three groups with significant decreases in pain, showing that all of them seemed to be effective. Now, they commit a lot of text in the article to talking about the temporal trends of analgesia, but they don't go past 1 hour of pain control, which is a little bit unfortunate. They did have an interesting group, though, in that they could say that patients with more fractures, up to more than 5, had more pain. So they definitely had some very traumatized patients. Also interesting was that I would have thought that upper extremity fractures would have higher pain scores. Just, it's easier for you to pay attention to and to see it, but I guess paying all that attention to it means you don't move it as much. And indeed, lower extremity fractures, perhaps because they're more dependent, more swelling, bigger bones means greater mechanism, I'm not sure, but lower extremity fractures seem to have more pain. A notable limitation from the trial was that they tried to recruit 600-something patients, and 460 of those patients refused, resulting in their 140 sample. I mean, honestly, if I came in with a fracture and you're like, hey, we're going to try something new for you for your pain, I'd be like, yeah, maybe leave me alone. Yeah, maybe I want real pain control. I clearly have a broken bone. So I don't blame these patients for refusing, but it is nice to see that all of these pain control methods are definitely effective. I think where this could be most useful is probably in the pre-hospital setting where it's hard to get an IV particularly. And so you could just give them a sniff of ketamine and control their pain on the way to the hospital. Very safe medication as well. Sounds like a pretty good deal. Now, is 1 milligram per kg going to be the ideal dose for these patients? I'm not necessarily thinking that that's the case. Already 0.5 milligrams per kg, you're going to get a lot of dissociation effects in those patients. So perhaps we could do a little bit more dose finding to see if 1 milligram per kg is the appropriate dose intranasal. But at the very least, we know that this seems to be a rather effective dose. I think that with closer attention to the dissociative effects, which were not necessarily polled in this study specifically, we would probably see more side effects on that side of things, definitely with the dose of 0.5 milligrams per kg IV. As you can see from other trials, patients are definitely going to get a lot of dissociative effects from that dose. In a spoonful, intranasal ketamine, IV ketamine, and weight-based dosing of morphine seem to all be effective modes of analgesia for fracture pain, at least up until 1 hour. So what did we learn today? Let's do a quick wrap up. From the first article, don't just give out SABAs, also always add inhaled corticosteroids. From the fourth article, if you can't get an IV, you can use intranasal ketamine, which seems to work quite well for pain. If you are hearing this right now, then you only got part of the podcast. If you'd like more podcasts, then you'll have to become a member. What did you miss from this last week? Well, we had a precise look at what is the risk of stroke post-TIA. We did a reanalysis of a trial on coronary artery dissection, digging deep into the indications for possibly anticoagulation. And then we heard the whole story about Reboa. Links to all the original articles can be found at journalfeed.org. Just follow the links in your show notes. Our goal here is for you to read less, learn more, and save lives, one spoonful at a time. Thank you.